So this is a picture of my eye indoors with the pupil somewhat dilated. And here's my eye outdoors with the pupil somewhat constricted. So what's going on here? What's the physiology?
So now we're considering the iris, which extends from the ciliary muscles, part of the choroid layer, and the pupil, which is simply the gap in between the iris diaphragm. Now if we look at the eye from the front, here we have roughly an eye. So there we have an eye, and the iris is the coloured component and the pupil's in the middle. So if you have blue eyes, then that's going to be bluish. It's the coloured part of the eye, the iris. And the pupil actually looks dark because the pupil is going through to the inside of the eye. And there are pigmented layers of the retina and pigmented layers in the choroid, so the light is not reflected out of the eye again. So the light that's not used for generating the electrical nerve impulses, that's not used for transduction, it's absorbed by the pigmented layers inside the eye, so you don't get a lot of light coming out from the eye, so it looks dark in colour. Now, the amazing thing about the pupil, of course, is it can constrict and it can dilate. So let's first of all think about constriction of the pupil. Pupil constriction. So what's happening when the pupils constrict? Well, pupil constriction is generated by circular fibres. So if we think about the iris here, imagine that's the iris, with the pupil in the middle. Now the circular fibres around about in the iris, the circular fibres. So the circular fibres here, smooth muscle fibres. And when these circular muscle fibres contract, that will reduce the size of the pupil. There's going to be constriction. These are called the sphincter pupillae muscles. So as these contract, that's going to reduce the size of the pupil. So contraction of the sphincter pupillae, or the pupillae muscles, sphincter pupillae muscles, will bring that in, will contract it down the way. And this is a parasympathetic activity. It's brought about by parasympathetic stimulation, primarily by the third cranial nerve. It's brought about by the nerve called the oculomotor nerve, which is the third cranial nerve, arising from the midbrain and going into the eye. It's the same nerve that actually controls a different branch, but the same nerve that controlled the ciliary muscles. So the contraction of the circular muscles is reducing the size of the pupil. Contraction of the sphincter pupillae muscles. We get contraction of the pupil. Now there can be abnormal contraction of the pupil that we have to look out for. For example, in people who've taken overdose of opiates, the pupils can become very small, like pinpoint pupils. And it will be the same on both sides. Both pupils will be pinpoint in opiate overdose. Or it can indicate rarer conditions such as hemorrhage in the pons of the brain stem. Or another one is organophosphate poisoning can give a pinpoint pupil. So important clinical indicator. In all those conditions, of course, both pupils will be equal in both eyes. And also constriction of the pupil will be brought about if you hold your finger out and bring it closer to someone's eyes and ask them to focus on it. So as we try to focus on close objects, the pupil will also narrow and the lens will thicken. And the reason for this is that if the pupil is more narrow, we'll get better depth of field of our image when we're looking at close-up objects, as photographers amongst you will know. Now, the converse of constriction, of course, is pupil dilation. The pupils can also dilate. So when we go into a dark room, the pupils will dilate to let more light in. Just the same as when we're in bright sunlight, the pupils will naturally constrict to let less light in, to control the amount of light going into the eyes. Now, pupil dilation is brought about by contraction of radial fibres, called dilator pupillae muscles. So if we think about the outside of the iris again, there's also radial muscles in this direction, in that direction. And when these muscles contract and get shorter, that's going to pull the pupil, going to open the pupil, going to dilate the pupil. So that's contraction of the radial fibres, the dilator pupillae. And the interesting thing about this is under sympathetic control. The sympathetic nervous system that widens and dilates the pupils. So the sympathetic nervous system, of course, is the fight or flight, emergency situations or excitement. We get dilation. Now, as we've said, this will naturally happen when we go into dark areas to let more light in, just as constriction will naturally happen when we're in bright light. But there's also clinical indicators, or it can be useful as a clinical indicator if someone's got dilated pupils. So drugs such as atropine will dilate pupils, but so will drugs that stimulate the sympathetic nervous system, such as methamphetamine and cocaine, for example, and some hallucinogens such as mescaline will do the same. So also a useful clinical indicator. Now, one of the key things about our observations of pupils is to note whether they are equal or not. So normally if we shine a light in one eye, if we think about both eyes here, we have an eye there and an eye there. And if we shine a light in one eye, then we would expect both pupils to constrict. And if one pupil dilates, we would expect them both to dilate. It would always happen together. So if you shine a light into that eye, yes, that pupil will dilate, will constrict if you shine a light in, but that one will as well. They're supposed to be the same. Now, if one pupil is wider than the other, that's a sign that there's usually something wrong within the central nervous system. So it's quite an important clinical indicator. So, for example, after a head injury, there might be compression of the oculomotor nerve on one side. Now, the oculomotor nerves don't cross over. So if the right pupil is not responding properly to light, if it's becoming sluggish or dilated, that indicates pressure on the right side of the brain. And in the same way, if the left pupil is not responding to light and the left pupil becomes dilated, then that means it's the left side of the brain where the problem is developing. So an important clinical indicator. We want to look at how the pupils are constricting, how quickly they constrict, but above all making sure that they are equal. But in the physiological situations, it's the parasympathetic that's causing the constriction and the sympathetic which is causing the dilation. The circular fibres constricting to bring about the constriction and the radial fibres constricting to bring about the dilation. So here we're looking at the retina in green. The optic nerve here is leaving the eye, that's the second cranial nerve, taking the visual information in towards the brain. But where the optic nerve leaves the eye, there's no light sensitive cells. So this area is described as the blind spot because we can't detect vision in that particular spot. The Macula Lutea is the bit that's in the direct line of sight. And that's very high in the very sensitive cone cells. The cone cells are the high resolution cells. Altogether, the eye contains about 6 million cone cells. There's also 120 million rod cells that detect dimmer light and slightly less resolution, or less resolution than the cones. But here there's a high density of cones, so very good visual acuity in that area. It's called the yellow spot. It's not very yellow actually, but that's what it's called. But at the centre of that, there is the fovea centralis, which is purely cones, nothing else. That depression there, in direct line of sight. And this whole structure in green is the retina. Now the retina does extend forward, but as the non-visual retina lining the ciliary body and the inside of the iris. But that's non-visual. Doesn't contain the light sensitive cells. Now if we think about this in a bit more detail, the retina is in two layers. So firstly on the outside we have the choroid. The choroid layer. And what we've done in these talks is we've drawn that in red. We'll maintain that. Have that in red. See the red choroid layer in the original diagram. And the retina is in two layers. The pigmented retina the pigmented layer, and on top of that the neural layer. And we drew the retina of course in green, so let's maintain that tradition. The pigmented layer next to the choroid and the neural layer above that. So the outer pigmented layer contains melanocytes and melanin, this layer here, to absorb any excess light. Actually, people with albinism, albinos, don't produce the melanin, and they do get dazzled by light quite readily because the light rays can bounce around inside the eyeball if they're not absorbed efficiently by the melanin. So it's firmly attached to the choroid, and it continues anteriorly as the non-visual retinas are said to cover the internal surfaces of the ciliary body and iris. So we know that. Now the inner neural layer is the visual or the optic part of the retina. This is where all the light sensitive cells are located that take part in this process of transduction, lining the posterior 3/4 of the eyeball. So this is all the visual retina here, lining the back of the eyeball. Contains the rods and cone cells. And these are responsible for what's called transduction, transforming one form of energy into another. So they transform the electromagnetic radiation, which is the light energy, into electrochemical potentials, nerve impulses that travel in the optic nerve to the brain, the second cranial nerve, the optic nerve. So the retina, the visual retina, is the beginning of the neurological visual pathway. And it's actually, if you have a condition called a detached retina, what happens in a detached retina is that the visual layer separates from the pigmented layer. So this layer will separate, it will come away, and there will be a gap. That's the condition of detached retina. So detached retina is when the neural layer separates from the pigmented layer below. And of course that's an immediate sight-threatening condition that needs immediate medical attention. And the retina is interesting because it's the only part of the body where the blood vessels can be viewed directly. So we have the central retinal artery and the central retinal vein, and we can see the blood vessels. If we look through here with the ophthalmoscope, we can see the blood vessels directly. And with practice we can recognise hypertensive changes, we can recognise diabetes. And we can visualise the optic disc where the optic nerve leaves the eye. The optic disc is the blind spot. It's lighter coloured. And with a bit of practice we can see the difference in tone of the macula with the central depression of the fovea, which you can't really see with an ophthalmoscope. But you can see this area is a different tone in colour. So when you get the chance, do look at retinas with an ophthalmoscope. Take someone into a darkened room. Don't have the ophthalmoscope on full though, because it's very glary. Turn the light down and you'll find that the retina is indeed a very beautiful structure. There's many amazing things about the retina. I'm not going to go into detail in this clip. We'll talk about it in another clip. But we'll notice in the future that there's 3 layers: the photoreceptors, the bipolar cell layer and the ganglion layer. And for most of it, the ganglions are on the outside. It's just the fovea where the cones are exposed directly, but yet it gives us this amazing resolution. And the retina is also a very energy demanding tissue. It's very metabolically active for its size, as it transducts these light rays into electrical neuronal information, taking that information off towards the visual areas of the brain as nerve impulses in the optic nerve. So the retina, the light sensitive retina, is the organ of transduction, giving us this vital information about the outside world. Let's now look at the bony orbits in which the eyeballs are contained. So obviously there's bilateral, there's 2 of them. And the orbit is the socket into which the eyes fit and are protected, alongside other associated structures such as the extraocular muscles that are responsible for movement of the eye. So the orbit is the name of the cavity. And we see that there's an orbital rim surrounding it. And this is so important because it means if something's going to hit you, there's a good chance it will hit the bones of the orbital rim rather than penetrating in to damage the eye. So we do certainly see eye injuries in accident and emergency departments, but more often there's injuries to the orbital rim because the orbital rim is doing its job, protecting the precious, delicate contents of the orbital cavity. So the eyeball sits in here, it's got a roof and it's got a floor on both sides. Now I'm just going to give you a very quick run through the bones. This is the frontal bone here in brown, the frontal bone. And this large facial bone in orange is the maxilla. The mandible, of course, is the jawbone. The front teeth are in the top teeth are in the maxilla. And the famous facial bone on the side, one of the really characteristic human facial bones, in purple, is the zygomatic, forming this part of the rim. The zygomatic bone. Now, the sphenoid bone here is in red. The sphenoid bone. So if I can just point to the sphenoid bone, it's this one here. Just maybe zoom in on that a bit. So here we see the sphenoid bone. It's labelled 8 in this model. Of course, the same on both sides. the sphenoid bone. And this bone continues inside, in the cranial cavity. So this is the sphenoid bone here, continued in this red colour. We see the frontal bone from the inside there as well, of course, and this yellow bit is called the cribriform plate. It's part of the ethnoid bone. That's actually where the nasal nerves enter. The first cranial nerve is the olfactory nerve, bringing nerves of containing smell information from the nasal cavity into the brain. So up to the sphenoid there, you can see the sphenoid on the outside still in red here. But we see it inside the orbit there. Then the ethnoid bone is in yellow, which we see in here, labelled 9R on this model. And the same on that side. The ethnoid bone in yellow. And the lacrimal bone is labelled 10 on this model. It's a cream colour. That's the lacrimal bone. So there we see the yellow ethnoid bone and the creamy white coloured lacrimal bone inside the orbit. On top of the nose there, of course, we've got the nasal bone. There's actually a little bit of a palatine bone at the back, just about there as well, but it's not shown on this model. So there's actually 7 bones forming the orbital cavity. Now what else is of interest here is, can you see that hole there? Let me zoom in on that. There's kind of a hole there going through, just there. Oops, lost it. There. Hole going through there. And of course the same on the other side. Hole going through there. There we see it on both sides. And that is the optic foramen, where the optic nerve goes through, carrying the visual information into the cranial cavity. And actually what happens is some of the nerve fibres cross over just behind here, in that position there. And that is called the optic chiasma. Some of the nerve fibres cross over, some don't. We'll do a separate diagram of that. But you can see here where the optic nerves come through from the back of the eyeball into the cranial cavity, on their way back to the visual areas of the brain, which are in the back, in the occipital lobe of the brain here at the back. So their path has to run back like this towards the occipital lobes of the brain, which is where the vision is actually interpreted, where the vision is generated. There's this optic chiasma just there first, like that. Optic chiasma. There's other things we could talk about. I mean, there's the these gaps here. I don't think you can see there. Larger gap just there. Just lateral to the optic foramen. That's the superior orbital fissure. And down there's the inferior orbital fissure, which we can see there, that gap there. So these are areas in the bone where that gives us quite a clear view of the superior orbital fissure there. We can see right through there. That carries nerves and the superior ophthalmic vein and the inferior orbital fissure just here. That carries various cranial nerves again in the inferior optic vein. It's a very delicate, beautiful structure. It's good that you can see it with these different colours. Temporal bone on the side there, part of the parietal bone. Occipital bone at the back of the skull. The sutures in between the bones. But that's just to give an impression of the orbital cavities in the skull, which is such a defining characteristic human feature.